Today, Dr. Tamil Selvi, Madam from Professor and Head Department of Pathology from Variyar Medical College, Salem, would present the SLOs in male genital tract and also dermatopathology. Madam has taken a great effort despite a very, very hectic schedule. Madam, thanks to you and very grateful to you. And so that today we are holding Friday webinar at 1 o'clock due to Madam's efforts. So kindly over to you, Madam. Please start the session.
Good afternoon, all the participants. I would like to thank the organizer and also Dr. Vinaya Sharma giving this opportunity to present the competency-based medical education pathology here. They're writing the SLOs on male genital tract and dermatopathology. The number of competency according to the MCA it is given in male genital tract will be number 5. The number of procedure that requires certification is nil. So these are the competency given by the MCA documents, pathology 29.1, 2, 0.3, 0.4 and 0.5. So these are the things. Today I'll be going each competency, how we'll write the SLOs. So number 1 will be pathology 29.1, classify testicular tumors, describe the pathogenesis, pathology, presenting and distinguishing features, diagnostic, progression and spread of testicular tumors. So at the end of this session, this phase 2 or a second MBBS student must be able to classify testicular tumors, knowledge level, shows how, and it is a core competency. Enumerate the etiology of testicular tumors, including intratubular germs and neoplasia you have to discuss in detail. And the third will be discuss the pathogenesis and pathology of testicular tumors. And fourth one will be list the clinical features, spread of tumors, stages of tumors, and list the lab diagnosis of testicular tumors, including the tumor markers. So all these are at the domain level, it is a knowledge level, and it shows how, and the core competency will be core competence level. The teaching learning method, mostly it is taken as covered as a lecture. When we start, we can say small group discussion when we can start, or we can put a case-based discussion we can start and go into a lecture also. Then regarding this, there will be a specimen will be available, slides will be there for undergraduate. We can do a dope section also. Assessment will be mostly, it can be asked as a long answer question, short answer question, then multiple choice questions, and viva also will ask. Then we can put it as a OSPI also. And then it can be taken as a integrated lecture along with the surgery department. We can do that. Yes, ma'am. Shall I proceed for next slide or shall I wait, ma'am?
Any thought on this? Can Madam go ahead? Yes, Madam. Go ahead. Let's after 2-3 we'll start taking it together.
Okay, ma'am. Okay, ma'am. Pathology 29.2, describe pathogenesis, pathology, presenting features, distinguishing features, diagnostic test, progression, and spread of carcinoma of penis. At the end of this session, the second MBBS student must be able to enumerate the etiology of carcinoma of penis, including the pre-malignant lesions. Others we have to discuss the pathogenesis and pathology of carcinoma of penis, list the clinical manifestation and spread of carcinoma of penis, list the lab diagnosis of carcinoma of penis. At this domain level, all these are knowledge level, and level will be knows how. Then core competency all are. Then teaching learning method could be lecture. As you say, small group discussion we can do. We can put a case-based discussion also. We can start the program. The assessment will be mostly it is a short answer questions, multiple choice questions, and it can be asked in the viva voice also. And this lecture also we can take as a integration along with the surgery department.
Yes, Madam, go ahead. I'm not seeing any hands raised, Madam.
Shall I proceed next? Pathology 29.3 and 29.4 together I'm discussing here. I'll be telling you the last point, I'll mention it. Describe the pathogenesis, pathology, hormonal dependency, presenting and distinguishing features, urological findings, and diagnostic test for benign prostatic hyperplasia, and progression and spread of carcinoma of prostate. At the end of this lecture session, the second MBBS student must be able to enumerate the etiology of benign prostatic hyperplasia and carcinoma of prostate, discuss the pathogenesis and morphology of benign prostatic hyperplasia and carcinoma of prostate, list the clinical manifestation, course of the benign prostatic hyperplasia and spread of carcinoma of prostate, list the lab diagnosis for benign prostatic hyperplasia and carcinoma of prostate. These all will be knowing the domain level, will be knowledge level, the level of knows will be knows how. Then the core competency, all will be the core competency. The teaching learning method, we can start as a case-based discussion, then we'll go into the proper lecture, or we can put it as a small group discussion also when we start. And at this juncture, I want to tell one more competency given by the MCA 29.5, that is define and enumerate the etiology of prostatitis. That is non-core only. We can, at the start of this lecture alone, we can start with the inflammation of the prostate, then we go into the benign prostate hyperplasia and carcinoma prostate in detail. So we can merge together all three things together. 29.3, 29.4, 29.5 pathology. We can merge together. We can take as a one lectures, madam. So it can be asked as a short answer question, multiple choice question, 5 hours, and it can be taken as an integration along with the surgery department if possible.
Any input, any feedback from the participants? Okay, madam. There's no raising hands. Yeah.
Okay. The dope section, usually we'll have undergraduate level. During practicals, we'll have a gross specimens, slides will be there, and charts also we can make regarding the testicular specimens, seminoma, mixed germ cell tumors, embryonal carcinoma, because they should know variegated appearance. In seminoma, uniform homogeneous appearance they must know. Because of that, we can put it as a various specimens. Then in benign prostate hyperplasia, we'll receive always multiple pieces. If they are left out pieces, we can show. Otherwise, we cannot do. Always we'll be putting all embedded, so there won't be any specimen at all. Okay, if at all, we can show that. Then if accidentally when we get a carcinoma prostate in entire total specimen, we can show. Otherwise, it is not possible. We can get a photograph and we can show that this is a carcinoma prostate, showing the lobes and showing a very appearance like the tumor appearance. We can show that. Then carcinoma penis, always will get a sample. So total phenectomy or partial phenectomy specimen showing a cauliflower-like growth we can show, and we can teach them during class practical hours. This last one we put it for us, dermatopathology, squamous cell carcinoma, basal cell carcinoma, malignant melanoma. It can be gross specimen or it can be shown as a slide that we are included, that will be discussed later. So here I am put it the gross specimen cut surface of the testicular tumors and also microscopy section of the seminoma. As undergraduate, they must know. Apart from that, we can prepare a chart also. We can ask some questions. Yes, ma'am.
Yes, madam. Madam Shagufta, madam. Anyone wants to say anything, madam? Okay. Okay, madam. Go ahead, ma'am.
Then we'll move on to case-based discussion in the male genital tract. This is a 35-year-old man has noticed that feeling of heaviness, swelling of the scrotum for 1 year duration. On physical examination, the right testis is thrice its time enlarged, and it is firm and slightly tender. An ultrasound examination shows 4 centimeters of solid mass in the right testis. Laboratory findings shows markedly increased serum levels of chorionic chondrotrophins and alpha fetoprotein. Which of the following testicular neoplasm is most likely diagnosis? So I'm given the ABCD. So from that, they have to read the clinical scenario, the age group, and also the duration, the what is the clinical presentation, the tumor size, then the lab findings, they should correlate. Then they will come to the diagnosis, what is that. So here the answer is mixed germ cell tumor because of the hormone level, both are elevated here. So significant elevation of alpha fetoprotein level that does not occurs in the pure seminoma. Elevated levels of alpha fetoprotein and HCG efficiently exclude the diagnosis of pure seminoma. It indicates there is a presence of non-seminomatous tumor of the mixed type. Teratocarcinoma tumors with the elements of teratoma, embryonal carcinoma, and yolk sac tumor will be there. Yolk sac element will have a high level of alpha fetoprotein. Leydig cell tumors are non-germ cell tumor. They are derived from the interstitial or Leydig cells. They elaborate androgens. Choriocarcinoma secrete high levels of HCG, but there is no alpha fetoprotein. That they should understand. For that, I brought it here.
Okay, ma'am.
Case number two. 32-year-old man tried to conceive a child for 8 years, and now they undergo infertility workup. On physical examination, both are normal. Okay, male and female, both are husband and wife, they are normal. Laboratory study shows sperm count is low. Microscopic examination of seminal fluid, the sperm count is low. Normal morphological appearance. Then subsequently they did a testicular biopsy. The biopsy specimen shows focal atrophy of seminiferous tubule, but the remaining tubules show active spermatogenesis. Which of the following disorders is the most likely cause of these findings? So cryptorchidism, mumps virus infection, syphilis, Klinefelter syndrome. So here they should know some infection also affects the testis and produces the lesion. So mumps, initially the patient had parotid inflammation followed by the clinical presentation. Now he presented with the orchitis. So like that, the clinical correlation they should bring it. Focal atrophy, loss of seminiferous tubule that indicates local inflammatory processes going on. Cryptorchidism result from failure of the testis to descend to the scrotum normally. The abnormality of the position testis becomes total atrophy. That they should understand. Syphilitic orchitis we have to discuss where it is affect first. Then what is the presentation regarding the syphilis, gamma, granulomatous inflammation, like that we have to discuss. Then Klinefelter syndrome and estrogen therapy can cause tubular atrophy. It is a generalized in both the cases.
Madam Shagupta madam, please unmute yourself. Madam Shagupta madam, unmute yourself, madam.
Good afternoon, ma'am.
Yes, ma'am.
Am I audible?
Yes, madam.
Ma'am, I had a comment regarding this particular case. As madam is trying to highlight this problem about, because there is not much to do with these ILOs, they are very few, but we can make this particular system interesting by putting interesting cases. So as madam has rightly put this case for consideration of the infectious etiology for infertility. Am I right, ma'am? That's the idea of your case.
Madam, sure. Yes, ma'am.
Yes, ma'am. So
yes,
could we just add a part of a part in the scenario about tuberculosis, because you see tuberculosis epididymitis is also one of the very frequent causes of infertility in men. So Klinefelter syndrome and again, tuberculosis is very common, and actually the clinicians, they never think of those causes, tuberculosis epididymitis and tuberculosis of the fallopian tube. These are some of the causes of infertility that are less investigated, but actually very common. So if we could include that, and that would make this case very comprehensive. And one more comment, ma'am, Dr. Vinaya, I just noticed that all of us are putting these case-based learning
yes,
in all of the systems, but I'm not sure if everybody is including the tutor guide. So they have to also add the tutor guide. I remember when Dr. Anshu, she gave us this webinar about case-based learning. At that time, she mentioned that for every case-based learning, whatever examples we are going to put, we have to add a tutor's guide, because that will be given to the student, will be given to the faculty. So it will be very useful for the entire faculty if they have this tutor guide. So it's just one of my suggestions that all of us, when we are putting, I don't know about the rest, but when for the systems that I presented for all the case-based learning, I generated a tutor guide as Dr. Anshu had asked us to. So do keep that in mind, do keep track of that.
Yes, madam, that will very well taken, madam. Definitely that needs to be done at the local, when we are actually implementing at a college level, the tutor guide will be taken care of and will be done. Yes,
not at the college level, ma'am. Now when we are generating these cases, so that will be a guidance, that will be the guideline. Along with these cases, those will be the guidelines. Later on, the colleges, they will follow those guidelines. They will develop their own cases and they will have a tutor guide. They will follow those tutor guide.
Yes.
They may develop different cases. They may not follow the same cases. They may develop their own cases, but they will have the tutor guide as a guideline. So we have to develop that tutor guide based on the cases that we have presented in our webinars and add to the document, so that that will be in the living document, as Dr. Sanjay was telling us the other day, given to the MCI. So once this gets approved from the MCI, then it is circulated. So all the faculty all over the country will have a tutor guide example, and then they will develop their own tutor guides. That was just one of my comments, ma'am. Thank you very much, ma'am.
Yes, ma'am. Definitely, madam. Well taken. Yeah, we'll do that, madam. Yes. Madam, go ahead.
Together to implement that.
Hello. Madam, shall I proceed?
Yes,
Hello.
madam.
Case
Yes, madam.
number three, a 16-year-old boy comes with the complaints of local pain and irritation with difficulty urination over past 2 years. He describes his erection as painful. On examination, shows that he is not circumscribed and the profuse foreskin cannot be easily retracted over the glans penis. What is the most likely diagnosis? Phimosis, paraphimosis, bovinoid papillosis, hypospadiasis. So these areas we will not concentrate mainly during our session. So because of that, I brought it this. Phimosis, answer. Repeated episodes of balanitis, inflammation of the glans penis and foreskin. So they will be knowing that what is paraphimosis, what is bovinoid papillosis and hypospadiasis also. They will be come to know learning part. So fourth one, microscopic examination of the biopsy specimen is given here. The picture shows arrows also. What is the most likely diagnosis? Which viral infection that causes the disease? What are the other pre-malignant conditions? And what type of malignancy they develop? So the answer is Bowen's disease, which is a form of squamous cell carcinoma in situ. Human papilloma virus infection 16 and 18 that commonly causes. And other condition related to that will be bovinoid papillosis. And this is a pre-malignant condition. They may go develop the squamous cell carcinoma. Question number 5. A 33-year-old male has an enlarged firm left testis, but no other remarkable findings. The gross and microscopic picture is given here. So they can nicely see the gross cut surface of the picture, microscopic picture. Based on that, we can ask, I put sample of the questions, we can ask anything, ma'am. What is your diagnosis? Mention the types and mention the tumor markers of general we can discuss.
Yes,
question, a 5-month-old baby, the parents has noticed that absence of one side of testis. On examination confirms the findings of absence. Which of the following is the most likely diagnosis? Anarchia, Klinefelter syndrome, cryptorchidism, macroorchidism. The answer would be C. So we can discuss other findings also. Congenital absence of both testes, anarchia, then features of Klinefelter syndrome, what will happen there? Then macroorchidism, what is it? Where will you see? Like that we can discuss in that. Question number 7. A 75-year-old man was admitted to the hospital due to acute urinary tract obstruction. For the past, the picture I could not read. He has had a recurrent bouts of cystitis. Just before a day before he admitted in the hospital, he could not pass the urine. So what is the probable cause of bladder outlet obstruction in this patient? So the ABCD answer is given here. The answer could be for this age group with a repeated respiratory infection or urinary tract recurrent bouts of cystitis and obstruction. We can put it as a nodular prostatic hyperplasia. That could be the answer. Question number 8. 35-year-old, a tall, slender, 16-year-old boy presented with a breast enlargement. Cytogenetic study revealed 47XXY karyotype. Which of the following urogenital disorder may be suspected in this patient? A, B, C, D are given here. Here we have to put it as answer D. Testicular atrophy. Testicular atrophy is typically found in patient with a Klinefelter syndrome. So image is given here. So what is your diagnosis? Describe the gross appearance of this lesion. What is the cause for this lesion? And mention the common infective organism that affects the testis. We can discuss here. Whatever the organism which affect and produces orchitis, common and uncommon organism also we can discuss here. Shall I move on to case-based learning, ma'am?
Yes, ma'am.
Then the 36-year-old male with a no significant medical history presented to the hospital with a unilateral 15 centimeter painless testicular mass and significant abdominal pain. Patient has noticed that right side testicular swelling. He experienced no associated pain at that time and the swelling progressed over the next few months. Lab findings: beta HCG 75 milliliter IU per ml. LDH level is elevated more than 4,000 units per liter. Alpha beta protein 3 nanogram per ml. Ultrasound showed testicles showed a markedly enlarged and heterogeneous right testicles and mildly enlarged right epidermis with a moderate hydrocele. Given the history, findings of total mass, there was a recommendation for further imaging to evaluate for this malignancy because of the lab findings, other associated findings. So they went on other investigation, chest X-ray they did, abdominal density to the left side of the descending aorta with a differential diagnosis of esophageal diverticulum, mediastinal mass or a lymphadenopathy they thought. Then they underwent a CT thorax, abdomen, pelvis was performed, revealed large heterogeneous right testicular mass with the extensive pelvic, retroperitoneal and mediastinal lymphadenopathy suggestive of testicular neoplasm with metastatic disease. So at this juncture, so they put it as a consideration. Choriocarcinoma was of primary consideration also they thought. So other investigation the patient underwent. The extensive retroperitoneal adenopathy was contribute to the severe right and moderate left hydronephrosis due to compression of the right renal artery and vein, causing hyperperfusion to the right kidney. And also there is a 9 mm of pleural based nodule was there in the right lower lobe, and there is a 10 mm of pleural based nodule in the left lower lobe were also there discovered. And an incidental pulmonary embolism also shown in the deep vein thrombus involving the femoral and external iliac vein bilaterally and extended to the inferior vena cava. The metastatic spread also involved the left iliac bone, demonstrated by 9 mm size of the sclerotic lesion. So here they can able to read the spread of the tumor, where all it went the tumor like that, if they can do that. Based on that, following that, patient underwent a surgery. So removed the specimen, received the specimen, gross and microscopic appearance is given here. So we can show some specimen and we can ask some questions also. So based on that, I put some of the questions here, typed it. What is your diagnosis? What are the differential diagnosis? What are the investigation you want to do for this patient? Like that we can ask. What are the investigation in that highlighted we can ask? Mention the mode of spread of tumors. Mention the stages of this tumor. Mention the prognosis of this tumor.
Okay, ma'am. Any feedback?
Proceed, ma'am.
Yes, madam.
Yes, we'll proceed for multiple choice question. Prostatic enlargement usually presents. A, B, C, D answer here it is given choice. So here one best answer they have to answer it with a difficulty in urination. Which of the following true about testicular tumor? It is not often a radiation sensitive seminoma. It is not it is a common cause of cancer death in older male greater than 50 years. Usually occurs in a young adult male 25 to 35 years. It is usually detected because of the hematuria. So here answer will be usually the testicular tumor occurs in young adult males 25 to 35 years. All of the following true statement about prostatic hyperplasia except it predisposed to carcinoma, it produces urinary tract obstruction, it predisposed to urinary tract infection, it produces urinary obstruction, and it is a result of benign glandular and stromal proliferation. So here except answer will be the A. Remaining all it will be true about benign prostatic hyperplasia. Question number 4. Adenocarcinoma prostate spread to the and involve the local tissue and to the bones. At this stage, the blood levels of prostate secreting the tumor marker PSA, which is elevated. Hello?
Hello, yes, madam.
Ma'am, screen it's not seen.
No, we can see the screen, madam. Okay.
I could not see. Wait.
Your screen is visible?
For me, it is not visible, sir.
Okay.
What to do?
So, what has to be done?
Okay. Wait, you must have minimized it. There is a flower. There is a flower at the bottom. You must have
click that,
minimized.
madam.
I'll see, ma'am.
Yeah, click on the flower which is seen at the bottom, madam. That is go to webinar ka icon sign. Yes.
Yeah. Wait.
Yeah, just click on that, it will come. The full screen will come again.
Yes, ma'am. Adenocarcinoma prostate spread to involve in local tissue and bones. At this stage, the blood levels of a prostate-secreting tumor marker is elevated. The marker is alpha-beta-protein, prostate-specific antigen, human chorionic gonadotropins, alkaline phosphatase. We can give answer prostate-specific antigen here. We can discuss about PSA, what is the normal level, where it is increased, decrease also we can discuss about. Which of the following statement true about testicular cancer is false? Testicular mass of a male age greater than equal 50 years of age should be regarded as a lymphoma unless proved otherwise. The incidence of testicular GCT has been decreasing lately. Cryptorchidism is associated with a several fold, has a higher risk of GCT. Inguinal cryptorchid testis are a higher risk than abdominal cryptorchid testis. So here the answer is D. Isochromosome or short term, in which chromosome is a pathognomonic of GCT? It is a isochromosome 12. It is responsible to produce a testicular tumor. So we can do integration, that case-based learning. I put it no long case and we are discussing. We can put it as a vertical integration involving the anatomy, pathology department, surgery department regarding the testicular tumor, or we can do something like sharing or nesting also can do. Yes, ma'am.
Any input from
Yes,
anyone? The male genital system, any feedback from anyone? Madam, I'll just see who has raised their hands.
I don't see any hands.
I don't see any hands, sir. And madam, we can go for dermatopath. We are going here because there are only few competencies dermatopath.
Yeah.
So we. Yes, madam. Please go ahead. Thank you, ma'am.
We'll start the dermatopathology SLOS. The topic is skin. Number of competency given here is 4. Number of procedure that require certification is nil. So these are the competency given by MCA document. Pathology 34.1, 34.2, 3.4. This is a total for a skin they are given. All things are knowledge level. Level will be knows how. And here they insisted the malignant melanoma and also the identify and common tumors of the skin as a core competency, remaining all non-core. And this will be put up as a dope session. So I'll be going in detail. So pathology 34.1. Describe the risk factors, pathogenesis, pathology, nature, and history of squamous cell carcinoma, basal cell carcinoma, and malignant melanoma of the skin. So SLO will be at the end of this session. The second MBBS student must be able to enumerate the risk factors of squamous cell carcinoma, basal cell carcinoma, and malignant melanoma of the skin, including all the pre-malignant conditions of the skin. Discuss the pathogenesis and morphology features of squamous cell carcinoma, basal cell carcinoma, and malignant melanoma. List the clinical manifestation and lab diagnosis of all the skin malignant tumors. Mention the spread and stages of tumors of malignant melanoma, including the Clark's column and anatomical level of spread of tumors also they must know. All these are domain at knowledge level, and level will be knows how, and it is a core competency, non-core, and the malignant melanoma and the dope session will be core level. Teaching learning method will be mostly it is taken as a lecture, small group discussion, or we can give it as a case-based discussion also. So here MCA norms, even they given the competency as a 4, the pathology 34.1, 0.2, 0.3, we can merge together with either we can take a 1 hour of lecture class, or we can during practicals also along with the dope we can able to cover. The can be assessment will be multiple choice question or short answer questions, multiple choice or viva choice. The dope section can be skill assessed during practicals. So it can be taken as a integration along with the dermatology department.
Dr. Shagufta, madam. Madam. Okay. Yes. Any feedback?
Questions, ma'am?
Yes, please continue.
Please continue.
Yes, sir. Yes, ma'am.
Lanjima sir wants to say something. Dr. Lanjewar, sir?
No, thank you very much. Very nice presentation. Yeah.
Thank you, sir. Sir, shall I proceed?
Yes, madam, please
Yes.
proceed.
These are the gross pictures we can show: squamous cell carcinoma, basal cell carcinoma, malignant melanoma, and we can teach some students and also make it a charts also. So here I'm giving some of the questions. 80-year-old farmer present with a 1 centimeter of red, slightly raised plaque on his face. Biopsy of the lesion shows cytological atypia and dyskeratosis limited to the basal layer of the stratum spongiosum, as well as hyperkeratosis and parakeratosis. The lesion is a precursor for which of the following dermatological diseases? A, B, C, D I am given here. So they have to click on that pre-malignant condition. Then we have to discuss the malignant condition. So the answer will be B, squamous cell carcinoma. Here we have to insist actinic keratosis, exposure of sun rays, they develop sun damaged area in the skin as a circumscribed keratotic patches or plaques commonly on the backs of the hand or in the face. Case number 2, 65-year-old woman presented with a facial discoloration. Patient observed to have a flat pigmented lesion on the atrophic sun damaged skin shown in the image. Image is here shown on the top. Which of the following is the most likely diagnosis? Acral lentiginous melanoma, alopecia, lentico-malignant melanoma, mucosal lentiginous melanoma. So the answer will be C, that is lentico-malignant melanoma. So we have to discuss what is the other name for that, and remaining all other types of malignant melanoma we can discuss here. So here we can say other ruling out answer also we can say alopecia is referred to hair loss, like that we can say. Mucosal lentiginous melanoma, where it occurs also we can able to discuss in that. So third question, a 60-year-old farmer present with several small papules nodules on the face of her neck. Biopsy of the nodule shown in the image shows the buds of atypical deeply basophilic keratinocytes extending from the overlying epidermis into the papillary dermis. Which of the following is the appropriate diagnosis for this condition? So it is easily at undergraduate level they will be knowing that. So the answer will be basal cell carcinoma. So we can discuss each and everything regarding the basal cell carcinoma, and what are the syndromes associated also we can put it as another question also we can bring it. If it is present with the multiple nodules like that, the nevoid syndrome also we can discuss. What is the leading cause of skin cancer? Fourth question, hereditary, exposure to chemicals, ultraviolet radiation exposure, moles on the skin. So even though we are reading all the causes of skin cancer, the most common leading cause we should know, that is exposure to radiation exposure. The answer is C. Fifth question, people that have a naturally dark skin tone do not get a skin cancer. True or false? It is a false. Even if it is a cloudy outside, you are still exposed to UV radiation to develop a skin cancer or not. True or false? So we should know this also. Clouds filter out the sunlight, but they are not filtering the UV light. So there is some exposure is there. We can develop a skin cancer like that. So okay, so that they should know. The following are true about squamous cell carcinoma. It is a common malignant skin tumor than the basal cell carcinoma. It only occurs on the skin. It is the most common skin tumor that's seen in a transplant patient, that is immunosuppressed patient. Metastasis usually to the regional lymph nodes. The tumor typically have a averted edges. Here it is C, there will be the answer. Remaining all you can put it as a other relevant answers you can give that. The cells involved in the formation of melanoma are basal cells, melanocytes, squamous cells, dendritic cells. We can say it is a melanocytes. Ultraviolet light leads to development of skin cancer by directly damaging the DNA, heating up the skin, inducing a vitamin D formation, causing water in the skin to vibrate widely, killing the immune cells located on the skin. So answer will be directly damaging the DNA. So we can discuss here the xeroderma pigmentosum, that is how the DNA repairing enzymes, all those things we can discuss based on this question. In malignant melanoma, the staging is according to the size of the tumor. True or false? It is false. It is according to the depth of the tumor by, we can say, Bruslow's classification we can able to discuss with this. 11th question, ABCD of skin cancer of the following except. So asymmetry of the skin growth, irregular border of the skin growth, color changes of skin growth, density of the skin growth in a particular body region, changes or evolution of a skin growth, which is not a correct answer for this. All of the following are true about skin cancer except this, especially in malignant melanoma. So here the answer is D. So I'm given the density of the skin growth related to, they should see diameter of the skin growth. Image is shown here. You can ask what is your diagnosis of this picture, which virus is responsible for this skin lesion, and describe the microscopic picture of this lesion. We can ask showing the images. So this is a last slide, ma'am.
Any feedback from this? Madam extensively covered, very comprehensive. Any feedback, madam? Anyone from the audience?
Ma'am, can I say something?
Yes, madam.
Yes.
Dr.
Ma'am, regarding the SLOs, can you please project that slide once again, because I couldn't unmute myself during these slides.
Yeah.
Can you go
Yes,
back
madam.
to that
Yes,
slide,
ma'am. I'll
ma'am?
go. The competency given in skin, ma'am, according to MCA documents. These are the MCA documents given here. Totally.
Yes, ma'am. You lumped three of
I
these
merged together everything as one. Yeah. This is
so
merged everything
that
as
means
one
we
session.
are going to just a second, ma'am. If I understood it right, we are going to cover basal cell carcinoma, squamous cell carcinoma, and malignant melanoma, all of it in 1 hour. Hello,
ma'am. During theory also we can cover, ma'am. During practicals also again we'll discuss, ma'am. Adanal we can take it as a 1 hour lecture. During practicals also we'll take, ma'am.
No, ma'am. I'm talking about the theory part. So in theory, when we are discussing squamous cell carcinoma, we are showing them the gross, the morphology, the microscopy, and then we are discussing basal cell. So each one will be at least 4 or 5 or 6 slides of PowerPoint. And then you are mentioning also the spread and staging of tumors, the Clark's classification. So it is too extensive, ma'am. It can't be covered in 1 hour lecture. I agree with you that we are going to be repeating that in the DOPS session, but DOPS is just to reinforce what we have taught in the lecture. It can't cover what we have missed in the lecture. So we have to cover certain things in the lecture, for example, gross, microscopy, pathogenesis, risk factors, genetics, now molecular becoming very important. So I don't think 1 hour will be enough, ma'am. Could you consider making it 2 or splitting it into 2 lectures at least?
But madam,
our time is 1.5 years reduced to 1 year, ma'am. In that only 10 months is available. If possible, we can do that, ma'am. That's all. If
madam,
we have extra amount, we can do that, ma'am. No problem in that.
Madam Shagupta madam, all these years here we have been giving only one lecture for this particular skin lecture. In one lecture we used to cover all this, or we can do it in such a way, as you said, pathogenesis, risk factors, that can be taken in lecture. Then with comparison cross, when we are doing that along with case, teaching can be done and emphasize the other things about squamous cell carcinoma, which has a nodular fungating mass, basal cell carcinoma, and melanoma. Melanoma, we can try to cover it along with the pathogenesis, the breast classification in the lecture. Then in the small group, we can, along with the specimens and chart-based and case-based, we can cover up the other aspects.
Anyway, ma'am, I am of the opinion that it should be at least 2 lectures, at least.
I agree, but
I think we can, the time is short, so we can maybe in the DOP, we will have to show something which are not covered in the theory.
Yeah.
Yes, sir. Yes, sir.
So we have to keep in mind that many students, they have the tendency not to attend the lecture or not to attend the lab. So somebody who attended the lecture will miss that part in the lab, and somebody
only hardly 10 or 10 months. Total time available.
We cannot.
We might have to maybe
year of duration reduced.
department. when skin people do it, we integrate with the skin department, and then with the skin people we can have this basal cell carcinoma and thing.
Maybe. Mostly dermatopathology people, na madam, in specialty, they deal with non-malignant, non-neoplastic skin lesions more than the neoplastic, where they just do excision and it comes to our surgical pathology section. So that's why the neoplastic is covered by pathology by showing specimens, gross, etc. Because I don't know, madam, agree. Because of the time constraints, because till now we have never given, we tried to cover, and along with the rest of the thing we have covered during a practical session where we have kept the specimens and the microscopy. They have 2 slides to draw: squamous cell carcinoma of the skin and basal cell carcinoma, where they know how to identify because of the peripheral palisading, which is highlighted, which is told to them. The melanoma, they now also we have them as a drawing slides in the practical journal. Okay, ma'am. Any other feedback?
Sanjeev sir.
It was good presentation, but for undergraduate, I felt some MCQs were very hard. That lentigo maligna, like that. Are we going to cover that? Even staging and things.
Sir, NEET exam students, sir.
Huh? Madam, 3 hours, 2 hours will not be enough then.
NEET students, sir, they have to prepare for NEET exam, so that we'll go for little high, then it will be useful for them.
Something they have to read, no? Everything you cannot read.
Yeah. Yes, sir. Yes, sir. I agree, sir.
And this dermatology, you said, all cancer cases, they go to surgery, skin cancer.
Yeah. But in the MCI document, they have mentioned as dermatology, venereology, and leprosy, sir.
They may mention, you suggest them, you suggest, they never operate.
Yeah, they have to combine with the surgery, sir. Combine with the surgery.
You might not surgery. But it was a very good presentation. I appreciate all of you, and this tutor, tutor note.
Yes, sir.
We must prepare for each and everything which has happened in the past. We can start that now also, so that we can complete. So take it seriously.
Yes.
Tutor notes are important.
Yes, sir, very true. So we still have few system SLOs left. Like next week, we have to decide what system to do. This week is over. Like next week, we still have major systems like female genital tract, which has 7, 8, 9 competencies. Then we have lymph node. Then we have bone and soft tissue, and full hemat we have hematology and blood banking. Blood banking is only one competency. So now I will require some people for next week or Tuesday and Friday. Then we can have webinars on Tuesdays and Fridays. So I've made a separate group in a common group. So anyone interested can join and can start working on that. So by next week, we'll have SLOs ready on those particular systems.
No, those who had prepared earlier SLOs, no?
Yes, sir.
Ask them to do that, tutor note. Because they are well versed with that. They have to read less and prepare notes. It will be easier. Yeah.
Yes, sir. So that can be done of the previous one, whoever is presented can be doing that. Okay, sir. I'll put it I'll put it in this to make a tutor guide note for the respective systems they have presented till now.
Absolutely.
Yeah. Dr. Thamil Selvi, madam, thank you so much for your very nice presentation, covering everything, even the minute things which we cannot cover in the lecture can be definitely covered and in your MCQs and in your chart base. So all the points are covered. Thank you, madam. I'm very grateful to you. You
Thank
took it at a very, very short notice, madam. I'm very sorry to, sorry also, I'm very, but thank you so much. I'm very grateful to you.
Thank you, ma'am. Thank you very much, ma'am. And there's Sanjay sir, and also Vinisha ma'am, and also Sagupta madam. Thank you very much, sir, giving this opportunity to share this session.
Thank you, ma'am.
Thank you very much, sir.
Thank you.
Thank you.
Yes, sir. Thank you, sir. No other questions, no, ma'am?
No, madam, I can't see any hand raised. Yeah.
Thank you, sir. Sanjay sir. Thank you, Vinaya ma'am, for your
Thank you
comprehensive
very much.
correction also. Thank you, Sagupta ma'am. All other participants.
Yes.
Thank you.